Hello, I'm Matthew Weinstock with Hospitals and Health Networks. As healthcare continues to evolve and the landscape continues to shift, hospital leaders need to continually assess how their organizations are going to adapt and remain viable in the future and grow their market shares. In 2014, Care New England, a 4-hospital system based in Rhode Island, launched Integra Community Care Network, an accountable care organization. The move to accept more financial risk has certainly had its ups and downs, especially in a state that never really embraced capitation. And I'm joined right now by Domenic Delmonico, Executive Director of Integra Community Care Network, to talk about some of the lessons learned in forming the ACO. Domenic, thanks for being with me.
Hi, Matt. Nice to be with you.
So first, give me a little bit of a profile of Care New England and your demographics, your market share. What is Care New England?
Well, Care New England is a 4-hospital system based in Rhode Island, as you said, total revenues of about $1 billion. And the interesting thing about Rhode Island, it's often used to compare as size of oil spills or farms in Texas. It's not very big, and it really lends itself to a lot of creativity because it is a small area. All 4 of our hospitals have academic affiliations. And so now the ACO is the new activity that we're doing at Care New England.
So let's talk a little bit about the formation of that ACO. What led the leadership team to think that, boy, now's the time to start taking on more financial risk and look towards an accountable care model?
I would say the single biggest thing was 4 years ago, Care New England hired a new CEO, and he came with a specified mission and one of his highest priorities of forming an accountable care organization. His background was in Massachusetts, and as you know, Massachusetts has been the starting point for a lot of this activity. Some would argue it was the basis for Obamacare, and his background had been to establish an ACO in Massachusetts and a Medicaid managed care organization, and his commitment and dedication to forming this ACO to get into population health was very strong and a high priority for us. Was
it something that those of you who had been there had thought about before he arrived?
Well, interestingly, as you know, for those of us with the gray hair and who have been around long enough, it's a cycle, and it comes back around. 20 years ago, almost to the day, we had formed a hospital-sponsored PPO. We had gotten into population health, and it appears that it's a bit cyclical, and so many of us have done that before. So when he came saying we're ready to restart, for those of us who had done it before, there was a strong receptivity for that.
So as you moved into starting to form the ACO and take on some financial risk, what were some key considerations that you looked at, and were you able to harken back to 20 years and look at some of the lessons learned from then?
I would say the biggest thing that pushed us ahead was a strong philosophical approach that said we are going to proceed ahead of preparedness. And I know that's a frightening thought, but for many in the hospital industry, that sense of waiting until you're ready or perfectly ready would keep you from getting into it. So that was very important. The notion that we've already done some of this, for our self-funded employee health plan, we've been taking risk for the last 10 years. And while some people might not consider it that way, we certainly did. And probably the biggest thing that was a concern or a challenge for us getting into this is we did not have a significant primary care contingent, and we had to be able to address that before we could move ahead. As you know, nearly all of these population health arrangements their attribution is based on primary care physicians and their patients. We didn't have a large primary care base. So we did 2 things around that. One was we acquired Memorial Hospital, where the family practice residency from Brown was based, a very important first step. And secondly, we formed a very close affiliation with the state's largest IPA called Rhode Island Primary Care. Had it not been for those 2 things, we would not have had the primary care base. And then as we went to apply for Medicare shared savings, one of their 2 bright lines is you have to have 5,000 attributed members to your primary care base. Had we not done those 2 first steps, we would not have met that requirement.
I'm curious about this notion of proceeding ahead of preparedness. So as you approached payers, employees, providers in the community, how do you talk to them about, we're going to go down this road even if we're not prepared, as you say?
A very interesting topic, especially for the physicians. As you mentioned at the outset, Rhode Island did not have a long experience with capitation, largely because we were a heavily PPO state, didn't lend itself to those kind of arrangements. So for our physicians, very few of them had experience with capitation. So our approach was that the early arrangements were shared savings without downside risk, which it was therefore easier to get the physicians engaged because they didn't have exposure to losses. And then for those arrangements like the Medicare bundle payment arrangement where there was downside risk, we took on that downside risk as the hospital. We capped the physician's upside risk, but in order to have the physicians feel comfortable that they could move into these arrangements, which for many of them, as I said, were new, we had to do those things and treat the early years as shared savings, no downside, and learning experiences, which I think has worked very well. On the insurer side, the largest commercial insurance state being Blue Cross Blue Shield, very interested and very eager to work with us on these new arrangements.
You've been in existence for about a year now, the ACO.
Almost to the date.
So what are some of the results that you've seen so far?
Well, the biggest thing that I could point to in terms of specifics is we found that our skilled nursing facility utilization was nearly double that of the national average. And the very specific result that I could point to is in our bundle payment arrangement for CHF, we found that discharges to SNF, that percentage has been nearly cut in half. And the second implication of that is that in that bundled arrangement, we went from losing money on every case to this last quarter of 2014, where we turned that into a profit per case. So we actually saw the economic improvement, as well as what we felt was better patient care by getting patients to rehabilitate in their homes rather than in a skilled facility.
Okay, I appreciate you taking some time to talk about what you're doing up there in Rhode Island.
Oh, you're certainly welcome, Matt.
And I'm Matthew Weinstock for Hospitals and Health Networks. Thanks for tuning in.